Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Hello, everybody. Welcome again to Ziada Academy. Today, I will show you a video, a newer video in the series of the Mission Impossible. I have displayed before a Mission Impossible in cataract surgery with a post-Uveitic retrocorneal membrane, and today I'm showing you the part 2 of this mission. Really, the dealing with the uveitic cataract is not that easy procedure. It's full of pitfalls, so you have to be ready and to know how to deal perfectly to save the tissues and get successful outcomes for the vision, for the eye quietness after the surgery. Despite, as you see in this picture, the retrocorneal membrane and the iris and the anterior chamber is totally quiet now. There is no active inflammation inside of the eye. But despite of the all therapies, you can guess for such patient, the inferior part of the limbs and the inferior part of the eye still congested, still angry, and despite of the old treatments. So after 3 months of treatment, I decided to operate this patient because he's not seeing anything by this eye, just light perception and a very hardly hand motion. Let's go for the video, and in this video, I will put the previous one in the description below to know the pitfalls that I have faced in different way in this case. So we have to learn from our mistakes. So I took a lot of lessons in the previous case and avoided the old mistakes in that case. The first one that I started peeling of the peripheral part of this membrane by injection of a lot of visco material, trying to separate the edge and get an edge to stretch after. As you see now with the spatula, I'm dissecting more than stretching. This is the the better way to dissect more than stretching. At the starting, you will complete it as you are peeling some membrane from another one, like the Descemet stripping, but I am trying to strip this membrane without stripping the Descemet together. So the mission is so difficult, and so I called it impossible mission because it's not expected to remove this membrane and still saving the Descemet membrane and the endothelium in place. But I have done it in the previous case and in this case too. So I'm now injecting a lot of visco material to separate the membrane and to keep the back of cornea. I'm now dissecting from each side, trying to strip the membrane from both sides, and then when I get this membrane free from the back of cornea, I can complete it by peeling and stretching from the anterior surface of iris. Now, as you see, it's totally separated from the back of cornea, and hence that the needle, the cannula of the methyl passed above it. It's passing above it now, and you can feel that the anterior chamber become with the same depth. Now, the second step to peel this membrane from the anterior surface of the iris. You will try as you can without sacrificing the iris. It's not wise to lose the iris or to do iris iridodialysis in this part. So I'm trying now to get an entrance between the membrane and the iris surface, and then I'm fixating the iris, pushing the iris against the stretching way of the membrane using this capsulorhexis microforceps. A lot of viscoelastic to keep the anterior chamber deep and protect the cornea. Then, yeah, I'm peeling, yeah, helping myself by fixation of the iris against. Yeah, finally, it's successful now. The membrane was peeled totally from the anterior surface of the iris, with some remnants on the iris, which is insignificant, and so I left it in place. Then I will start the phaco surgery by putting the iris hooks to dilate the pupil to deal with A's during the phaco emulsification steps. Starting the rhexis and trying to fashion it. It's difficult because the anterior surface of the surface of the anterior capsule is not regular, is not divide from the posterior synechia. And if you asked me why I have used just 3 iris hooks and didn't put the 4th one, I will tell you, unfortunately, I didn't find the 4th one. I got just the 3, so I I dealt with the situation with these 3, and it was working. I'm trying to complete, yeah, the anterior capsulotomy. I think it was a successful rhexis, then hydrosection. And despite this opacity is wide, but it's soft, and then I could remove it with the irrigation aspiration without using the phaco machine, then the implantation of the foldable IL, while the bag was filled of visco material, then dialing and centralization of the IL in the bag, which will work as scaffold for the coming or the next step. Then I removal of the iris hooks with one step and one hand, as you see. Then the next step to do pupilloplasty by using the straight needle 10-0 proline stitch and the technique of one pass 4-throw suture. And I have shown it many times in the previous videos how to do it. Yeah, it's one pass, 4-throw. The first throw, second one, third one, the 4th one, and to be sure I will pass with the 5th one. Then stretching both ends to make a good and strong knot. Then cutting with both ends, and then I will go for washing out the hyphema and cleaning the anterior chamber and putting this air bubble in this time to form the anterior chamber and to help pressing the oozing blood vessels and preventing the hyphema on the next day. But the hyphema is expected to find on the next day. Finally, I have to inject subconjunctival triamcinolone to decrease the reaction and help prevention of the aggressive postoperative inflammation, which is expected after this surgery. Honestly, I didn't expect the marvelous improvement for such patient. I will expect a post-operative severe iritis, but the Kinacort or the triamcinolone injected conjunctivally will help me to decrease the inflammation. Also, this patient is on systemic prednisolone 20 milligram tablets. The dose will be according to the age 1 to 2 milligram per day with gradual tapering, and also the topical prednisolone hourly with moxifloxacin eye drops hourly also, and cyclopentolate eye drops. I will tell you about the follow-up scenario for this patient. On the first day after surgery, there was a subtotal hyphema, especially in the lower part, while the upper part is devoided from the hyphema by the air bubble present in the upper half of the anterior chamber. The patient could see hand motion in the second day, and it's expected. So 1 week after, the hyphema disappeared, resolved at all, but the visual outcome in this patient was just 360 because of a membrane, pupillary membrane. And then I told the patient that this pupillary membrane will disappear within the coming 1 to 2 weeks with the topical treatment and the systemic treatment. So after 2 weeks, this patient came to my clinic with a better, status. The anterior chamber is much quieter. There is no signs of repeated or reactivated inflammation. The patient could see 660, but I didn't get any refraction for this patient because I will wait. I'm recording this video after 3 weeks from the surgery, but I will wait for 1 to 2 months after this surgery to get the best outcome. And I will show the final result in the description or the comments after that on following up this patient. Thank you for watching. I hope it beneficial video, and your comments, your constructive comments, your questions, and your guides are very welcome to see it in the comments on this video. Thank you very much. Bye-bye, and see you in the coming one.